Thanks, Animesh and the organizer for giving me this opportunity. So, welcome to all my colleagues for these sessions, management of non-driver mutated advanced NSCLC. So, now we are shifting from oncogenicity to immunogenicity. That means that it means a lot that all of us know that lots of immunotherapy is approved in the first line settings and subsequent lines of settings in advanced NSCLC, those who are non-driver mutated or some passenger mutation is there. And we know that all drugs are approved in the category 1 recommendation as per the NCCN. Pembrolizumab, nivolumab, ipilimumab, atezolizumab, celiplumab, and durvalumab is also coming. So we have in combinations. We have monotherapy, we have combo, chemo plus IO, we have IO, we have chemo plus IO plus anti-VEGF, ABCP, lots of things. So it is a very vast area for discussions, but I just compiled the slide deck because of the theme of this conference is controversies to consensus. So where the controversy lies in the advanced NSCLC. So there are some biomarkers is still there that we have to address in patient with non-driver NSCLC, particularly some biomarkers should be there before selection of the patient to IO drugs in combinations or in monotherapy. Suppose one biomarker is histology, squam versus non-squam. One biomarker is KRAS or BRAF or to some extent MET exon 14 skipping. These are the gray zone where we are in between oncogenicity versus immunogenicity. We have PDL1 expression, we have tumor mutational burden, we have some patient profile like non-smoker, like female, like it's brain metastases, liver disease kind of things, high tumor burden versus low tumor burden, and the combinations with these. So my thought of these panel is basically to focus on these area where can ideally select the patient and how to select the patients. So this is a flow chart in a short sequence that we know that platinum pemetrexed carboplatin based regimen is the first line non-squam histology along with the chemo, along with the immuno like pembro or atezo or maybe seriplimab. In monotherapy also PDL1 is high if it is monotherapy is approved, pembro, atezo, and in low PDL1 populations also combinations like pembro plus chemo or atezo plus chemo kind of things. So first is PDL1, low versus high versus negative, which clone and implications. Suppose I have SP263 DACO platform, someone has Ventana, someone has others. So are you prefer is any of these clone for the PDL1 selections? I shall go ahead with first with Dr. Schmidt.
The approved one is the 20C3, but data there that we can use it interchange. Immunotherapy also works. It has shown the similar kind of. So probably we can accept from other platform as well. I mean, yes.
Yeah. So definitely if someone has SP263, someone has 22C3 DACO, or someone has SP142, the study was showed that OS benefit was similar in the PDL1 high subgroup for atezo over chemotherapy, and it is maintained in with all platforms. It is prospectively validated. If we look at the median OS of atezo plus versus chemo in SP263 is 20 months, again it is 20 months, and again it is 19.5 months. So these are basically almost similar. Can you have a pointer, please, if you have? So these are things that we have to mention that any things we have either DACO or Ventana there is no point of using it interchangeably because median OS is almost similar in all these, whichever we are using. So another is tumor mutational burden. So what is tumor mutational burden? Tumor mutational burden is defined as the total number of non-synonymous mutations per sequence coding area in a tumor genome, yet to be considered as a robust biomarker, variable cutoff in literature, blood versus tissue. So how true surrogate biomarkers is it in tumor mutational burden? So I just like to ask on one of my panelists, Dr. Devapriya, we can take this, that are you comfortable with tumor mutational burden of 10, tumor mutational burden of 1.6, tumor mutational burden of 2.16, or are you comfortable with the blood versus tissue?
So tumor mutational burden is something that I would look at when considering immunotherapy in a PD-L1 negative uh, and driver negative population. And for me, high would be more than 10 mutations per MB, and blood or tissue, whichever, I mean, if it is high in either of them, then I can select the patient on immunotherapy.
So there is a zone of controversy of tumor mutational burden. If we look at this data of NSCLC, high harmonized tumor mutational burden score of 1.16 is almost equivalent to 16 tumor mutational burden in this study. These are the pooled foundation cohorts. Again, the foundation cohorts in blood versus tissue, there is some discrepancy of CDX or tumor mutational burden harmonizational score of high versus low. So foundation one liquid versus foundation one solid, there is some discrepancy. So where we are with the tumor mutational burden, it is still it's a zone of discussions, I think. So most of the studies and the guidelines says that if it is tumor mutational burden of more than 10, it should be a positive and is immunogenic rather whatever the PDL1 status. So that is one thing important. Now I just want to summarize the checkpoint inhibitors in advanced NSCLC. As a monotherapy, we have that pembro, atizo, and semiplimab. These are all approved indications, those who are without EGFR ALK ROS1. And more than PDL1 50%, the monotherapy is approved. Whereas in the combination, if we go to the combinations, non-squamous, squamous histology, particularly the non-squamous, the pembro chemo is the better, atizo chemo is the better. Whereas the squam, particularly pembro have data for this. And irrespective of both histology, we have nivo-EP combinations, we have that durva plus temilumab combinations and celilimab IM-Power Live. So these are the nutshells of irrespective, not only the all histologies is immune checkpoint inhibitors, we have to select the patient in that category, whether it is PDL1 high or PDL1 low, it is squamous or non-squamous. So histological subtype, which biomarkers are required for treatment making decisions prior to initiate immune-based treatment. One is histology and PDL1. I already mentioned that PDL1 is definitely in Keynote 042, the PDL1 loops, if we look at, the hazard ratio is more favored for the squamous histology in the pembro trial. Whereas in M-Power 01 lung, also the PDL1, irrespective of the PDL1, squamous is better. And Keynote 042 also. So my next question is, so if patient is a female, is a non-smoker, never smoker in fact, with some histology squamous versus non-squamous, how you select the IO drugs in your clinical practice? Dr. Shreya, you can take this.
For never smoker, that is a very controversial because never smoker is not that much good responder to immune checkpoint inhibitor. So that is a gray zone. And yes, the females, that is also, we have seen in the literature that the females are responder, but if we compare with the male patients, the female are not that much good responder to immunotherapy.
Yeah, so that is a dictum. We know that if oncogenic driver, female, non-smoker, Asian population, more prone for the EGFR TKI. But on the contrary, if we go to the immunogenicity, in the reverse, male, non-smoker, chronic smoker, this kind of is more prone for the immunogenicity. So the data literature also say like that way, that Keynote 042, M power lung 01 and IM power 110. If we look at the hazard ratio for the female, these are the hazard ratio for the female. These are the hazard ratio for the female. So they are basically not doing well with the IO checkpoint inhibitors. Again, I am showing the problem with the never smoker. The never smoker, if we look at the three trial comparison, cross trial comparison of Keynote 042, Keynote 042 and 24 and 42 and IM power 110, the subgroup analysis, particularly the never smoker, hazard ratio of 0.9, hazard ratio of 1 and hazard ratio of 1.83. So the hazard ratio in never smoker says that it not good for immunodrugs. So it is an unmet need for the never smoker with this female never smoker with the IO drugs. So these are the retrospective cohort of MSKCC data of more than 1,000 patients selected nationwide database originating from 280 US state clinical trials in the Pembro monotherapy. So if we look at the curve, the never smoker versus ever smokers, so there is a doubtful benefit with this cohort. So definitely we have to look at in a prospective way, so how it beneficial actually. Again, the gender, like we have look at the Keynote 042, male versus female. Female is almost crossing. IM power 110, M power 1, and the Keynote 042. So the male versus female, if we look at the subgroup, that female are not doing well with these, all of these across the trial. So female non-smoker is an urgent need. So what are the clinical characteristics might dictate differential decision-making process? Liver mets, CNS mets, squamous versus non-squamous, PD-L1 high versus low, IO monotherapy versus combo. Now I'm coming with one of the panelists, that Dr. Najiba, you can take this question, that if patient came with you with multiple liver metastasis, KRAS mutation positive with CNS disease, how you select this patient? It is an squamous. So you have plenty of options. Patient can afford anything. So how you select?
So in the absence of any driver mutation and patient has high metastasis burden, so I would like to start the patient. And is the patient PD-L1 positive?
It is PD-L1 negative.
Okay. So the patient can still be a candidate for chemo and immuno.
Chemo. So Dr. Jigok, you can take this. Which immuno drug are you select?
So if there is CNS Mets is positive, so I would go for CNS directed radiation first, and then we may go for the further systemic therapy. And here I think it's depending on the squamous or non-squamous histology. I think Pembro with combination with either taxane, carboplatin, and
yeah. So that's the thing. One clinically meaningful PFS benefit was observed in IM power 150, as my previous speaker is already mentioned. Those who are particularly liver metastasis is a meaningful survival benefit with the ABCP regimen in negative PD-L1 populations also. The arm A versus arm C, that is ABCP, is 34 months versus 34 months in the ABCP arm, and 23% patient was surviving with an median PFS of 5.4 months versus 8.2 months in the IM power 150 in the ABCP. So definitely, if patient is an disseminated liver metastasis with irrespective of the PDL1, ABCP will be the better option to select the data subgroup shared from the IM power 150. Again, dual inhibitors. If we look at the checkmate 9LA, the anti-CDLA4 plus PDL1, Nivo EP combinations. So the subgroup of checkmate 9LA, PDL1 less than 1%, PDL1 more than 1%, is a squamous histology versus non-squamous histology. So only 2 cycles chemo is allowed in this study. If patient is very much cachectic, not able to tolerate complete cycles of chemo, you can give the 2 cycles and then followed by the Nivi-EPO combinations. And it showed that the benefit was there irrespective of the histology as well as the PDL1 status. Now I'm coming to the CNS metastasis. And again the cross trial of Keynote 149, Pembro chemo, versus all the PDL1 is more than 50%, 1 to 49, less than 1%. So if we look at the overall response rate, it's almost is a very good response with a median survival benefit was there, and the hazard ratio is quite significant in more than 50% versus less than 50%. So in this histology, PDL1 expression, long-term benefit was driven by the Pembro chemo studies. Again, the brain metastasis, the checkmate 9LA is another study where in particularly look at the hazard ratio. Those who are baseline brain metastasis, I am telling that median OS is 19.3 months. Those without brain metastasis, median OS is 15.6 months. So Nivo-EP combinations in checkmate 9LA is eventually doing better in the baseline brain metastasis. So concomitant TP53 mutations with brain metastasis with a low PDL1 squamous histology or non-squamous, I think dual checkpoint inhibitor will be the better as per the checkmate 9LA data. So the dictum is IO mono versus combo if PDL1 more than 50%. The house of consensus, I would say that the similar outcomes with the monotherapy, IO combo versus IO mono if PDL1 more than 50. There is no doubt about that. It showed that the similar longer overall survival regardless of the strategy in terms of OS if PDL1 more than 50%. So if PDL1 is more than 50%, definitely IO monotherapy is better rather than the combo. But if PDL1 is 1.49% or even less, so combo is better than the monotherapy. And it was tested in this study, Keynote 042, Checkmate 227, Keynote 189, Keynote 0407, Keynote 021, IM power 150, IM power 130, and this trial. So all these trial that showed that combinations like chemo immuno is better if PDL1 is more than 1 to 49%. In the negative populations, definitely IO plus IO combination will be the better option in patient with a squamous with brain metastasis. So now my question is, Dr. Prashant. So co-mutations. We are talking about non-driver mutated, but that doesn't mean that any in CGP we have identified STK11, KEAP1, SMAD4. So co-mutation is an important. So some new drug, some new hope, and de-escalation based on the ctDNA assay. These are also important things to be considered when selecting the patient with the immune checkpoint inhibitors. So STK11 and KEAP1 is kind of mutation that is tested by the NGS, not only the all platform. If you have particularly Guardant, like foundation medicine, or Guardant liquid, or you have of your foundation or Guardant, these assays particularly identified STK11 and KEAP1 KRAS mutation concomitantly, but that is not is picked up by the hotspot mutation. So that the importance of Guardant or Oncomine precision assay or the foundation on liquid is to identify the co-mutations. The importance of these tests is identify the co-mutations, whether it is STK11 or KEAP1, because these are basically cold tumors. In concomitant mutation was there, these are basically resistant biomarker clones for the immunotherapy. So the addition of CTLA4 might improve the outcome in immune-resistant biomarker-defined subgroup, particularly if KRAS mutation, STK11 or TP53 mutation. The exploratory analysis of mutational status in the CheckMate 9LA that showed that they are doing better with the IO plus IO combinations. Even the IMpower 150, they are a subgroup, although the number of patient is very less, limited number of patient. Those are also KRAS mutation doing well with the ABCP. So in that category of patient, these are resistant biomarker subgroup not doing well with these IO monotherapy or IO chemo combinations that are to go ahead with the CheckMate 9LA protocol or ABCP protocol. So yeah.
Yes. So this STK11 or PIK1, though rare mutation, sometimes co-mutation, even when they are associated with KRAS, they just like create a immunosuppressive environment so that there will be less PD-L1 expression and less likely to be sensitive to immunotherapies. And so just like a state of de novo immunoresistance.
Yeah.
And if we can add like CTLA4, even the Durva and Tremelimumab trial.
I am coming.
So they have shown even 9LA, CheckMate 227, all these they have on subgroup analysis. They have shown this CTLA4 addition has improved survival in this 4 subgroup.
Correct. Absolutely correct that my colleagues that if this kind of commutation was there, we have to deal with the anti-CTLA4. It was tested and the trial is also going on. I am going into this part. Also, the CheckMate 227 exploratory analysis of biomarker-defined subgroup, those who are particularly resistant to immunotherapy, that they are doing very good with the Nivo-EP combination. If we look at the 17.7, 17.5 months, 10 months, and 20.2 months in particularly TP53 mutation. So P53 mutation is a very resistant clone and patient is very aggressive biology. Irrespective of the PD-L1, whatever the histology, we have to deal with this more aggressive way by the CheckMate 227 or CheckMate 9LA protocol. So again, the study is going on. The Triton trial is a phase 3 study where these particularly is addressed in this situation, STK11 KEAP or SMAD4, those how they are doing with the Durva plus Tremelimumab plus chemo, like ML induction kind of regimen. So these kind of things, aggressive way we have to go ahead and we have to look at the combinations, how it works. So another new hope of anti-LAG3 plus Nivo is an Relativity 104 study is ongoing. Result has not come yet. Some premature data has come. Irrespective of the PD-L1, those particularly in this subset is going on with the Nivo plus anti-LAG3 antibody. Now, can we perform de-escalation? Lastly, I am shortening, I'm all time. So, can we perform de-escalation strategy with immune checkpoint inhibitors? Sometimes I mean to say that patient is financial toxicity, but disease is controlled. So, can we stop this? Can we reduce the dose? Can we reduction the interval, 2 weeks, 3 weeks, 4 weeks, 6 weeks, because several studies, some 6 weeks regimen was there, some 4 weeks regimen was there, some 3 weeks regimen was there, not only the lung, but also the other subside of immunotherapy. And the increasing the schedule, reduce the dose, 100 milligram meter square, 100 milligram, 1 milligram per kg, 100 mg, 200 mg, these kind of things. So this is also an area of concern. And we have to look at the ctDNA based de-escalation strategy. Sushmita, you can highlight this if anything you had?
As of now, it's not standard to monitor ctDNA and based on that de-escalate, but probably we can stop the immunotherapy after 2 years because a study has shown the effect lasts even after 2 years, even if we stop the immunotherapy at 2 years.
Yeah. So can we stop treatment after 2 years, particularly in metastatic NSCLC with driver mutation negative. Patient is doing well with immune checkpoint inhibitors, goes on, and patient, can we stop this? There is some US data of 706 patient. Only 20% patients stop after 2 years, as well as some French data, 30% stop after 2 years. So no difference in OS for continue versus stop. So that's also an upcoming data, but all these studies that were ctDNA based approach, those who are ctDNA's level is detectable, undetectable, the concept of MRD, minimal residual disease, is coming in this subset. If MRD is negative, that is ctDNA load is very low, so we can stop this after a reasonable period of time. So that is also an important thing. We have to think about that, and further clinical research is going on. So now I'd like to thank my panel
Dr.
member
Somnath,
and all this.
I want to make one point
Yeah.
regarding de-escalation. Even the checkmate 2279LA, where some patients they have stopped due to toxicity, and those who have continued, they have compared the survival. The survival is exactly same.
Yeah.
So that means de-escalation is
Yes,
possible.
yes. So that's why I made this discussion that de-escalation is an reasonable options in this subset, particularly those who are not tolerating well due to toxicity, dose reduction, or the long-term effect. We have to see the long-term effect. Is it effect in the OS or PFS kind of things? So this is also an good important options. So I would like to thank my all panel members and the chairperson says any questions that.
Thank you, Dr. Roy and other panelists. We come to the conclusion of the panel discussion. One thing we have to ponder, whether we should go ahead with two immunotherapy, 3 immunotherapies with the overall survival of stage 4 disease, 3 to 5%. Whether we have to think about, because India is a resource.
Yeah, definitely. If we look at as a nutshells, 5-year survival is around 20% in this immune checkpoint inhibitor. All this across, we have 5 years data of keynote series. So the rationale of the thinking is 20% overall OS. It's not only so bad. If we look at the stage 3 NSCLC, the overall survival is not good beyond this way. So in a resource limited settings, definitely it is a good options to stop this therapy or de-escalations or some low dose immune checkpoint inhibitor data is coming. So we have to customize in that way how to give the maximum benefit with a reasonable cost.
Can the treatment be tailor-made? That is what I am asking. If
Yes.
the patient can afford,
yes,
then you can go away with 50 or lakh to 1 crore rupees, no issue. But in the government setups and in the other private hospitals.
Yes, definitely it is a challenge. Definitely is a challenge.
To all the parents.
And we have to look at the biosimilars also.
Thank you. Can we have a group photo? Thank you, Dr. Somnath Roy, all the panelists and the chairperson for putting up such an excellent and marvelous panel discussion.